We are back again here with the final of the basic spine webinar series from Asia Pacific Spine Society. And keeping up to the word of spreading and enduring the academia in spine surgery, Asia Pacific Spine Society takes pride in presenting you the third and the most awaited webinar on the osteoporotic spine challenges and fractures management and salvage options. And we have a wide array of faculty from across the globe, specifically from Asia Pacific Spine Society, to share their experiences through the widespread experience they have gained through the deliberations in next 2 hours. Without much ado, may I take this honor to invite our President of Asia Pacific Spine Society, Prof. Wong, to deliver the welcome address. Prof. Wong, over to you.
Thank you, Chair. Good afternoon, everyone. Welcome you all to this important webinar on fractures in osteoporotic spine. Asia Pacific region has a population of approximately 4.3 billion people, accounting for 60% of the world's population. According to the United Nations, the number of elderly people aged 60 or older is expected to nearly double from 700 million in 2023 to 1.3 billion by 2050. Osteoporosis is an inevitable consequence of aging, and so the incidence of osteoporotic spinal fractures will also increase. Therefore, spine surgeons should prepare to alleviate the suffering of these elderly patients who get fragility fractures of the spine and sacrum. Fixing osteoporotic bones is challenging. We certainly don't want to see failure, and patients need revision fixation because most of these patients are elderly, frail, and also have multiple medical problems. Next, I would like to borrow this opportunity to briefly introduce Asia Pacific Spine Society, APSS, to you. It was formerly known as the Spine Section of the Western Pacific Orthopaedic Association, WPOA. It was founded in 1979 as the first subspecialty section of the WPOA. In 2012, it was renamed as Asia Pacific Spine Society. It is the largest international spine society in the Asia Pacific region. Our mission is to advance the science, art, practice of spine surgery, and to promulgate the maintenance of professional standards to provide the best professional care for patients with spinal problems. APSS hosts many educational activities, such as webinars, basic, cadaveric, operative courses, to provide a learning platform for our members. Young surgeons in AP are very eager for our fellowship programs. All fellowships are organized by well-known, outstanding spine surgeons who provide experience and resources to help our young surgeons. We have more than 30 fellowship training centers in different regions of AP. We also promote and support collaborative research among countries and regions. In the past few years, APSS has published quite a few scientific papers. Please continue your support and join APSS. Before I finish, I would like to thank the dedication and contribution of first our chairman, Dr. Vishal Kundnani, our faculty, Dr. Vijay, Anand, Dr. Shin Oe, Dr. Shinji Takahashi. Also, I want to thank the case presenter and moderator, Dr. Chiu, Dr. Saturvelthan Chandirasegaran, Dr. Vijay Loya. Thank you, everyone. Without further ado, please enjoy the lectures.
Thank you, Prof. Wong, for a very insightful history and journey of Asia Pacific Spine Society. And that's what the strength of Asia Pacific Spine Society is. 60 countries 7 territories, and more than 11,000 spine surgeons in the reign of Asia Pacific Spine Society is the strength of Asia Pacific Spine Society. And I'm sure many of us today are going to be spreading the knowledge to reach out to all these 11,000 members and more across the globe beyond the reigns of Asia Pacific Spine Society. So we have a wide array of faculty from Japan, from Malaysia, and of course from India. Dr. Vijay Anand, Dr. Shinji Takahashi, Dr. Shin Oe, Dr. Saturvelthan, Dr. Vijay Loya, and Chee. I welcome you all on behalf of Asia Pacific Spine Society. The academic program will be run by Dr. Chee and Dr. Vijay Loya. I preside this and request you both to please moderate the session and take it forward. Dr. Chee and Vijay.
Thank you, Dr. Vishal. Thank you to Dr. Wong for his presentation. Now I'll invite Dr. Shinji Takahashi for his talk on balloon kyphoplasty for osteoporotic vertebral fracture. Dr. Shinji.
Okay, I have pre-recorded the video, so please start my video. Today I'd like to talk about the balloon kyphoplasty for osteoporotic vertebral fracture, indication technique, and surgical tips. Many papers demonstrated that the effectiveness of vertebroplasty. However, the two randomized controlled trials demonstrated that the no superiority of the vertebroplasty. However, the other papers, many papers demonstrated the effectiveness, so which means the patient's selection is very important. This paper selected the patients with their less than 6 weeks from the onset. This paper demonstrated that the effectiveness of balloon kyphoplasty and the subjects were the less than 3 months, and the BKP group improved the QOL, back pain, and disability comparing with non-surgical management. And also balloon kyphoplasty have more effectiveness in the survival rates. The two papers demonstrated that the better results comparing with vertebroplasty and conservative therapy. And the patient selection is very important. So because the majority of patients achieve the healing through the conservative treatment, and the timing of surgical intervention significantly impacts the clinical outcome. So about more than 80% of patients heal within a few months by the conservative treatment. However, about 15% of patients show the non-union, and a few percentage of patients the neurological deficits. This paper shows the change of back pain, and the patients with poor prognosis shows the greater back pain at 1 month comparing with the patients with good outcome. And the risk factor for prognosis were reported by the many papers, so especially the posterior valve injury, thoracolumbar junction, MRI findings, and huge instability are related to non-union. And so, for example, these MRI findings, such as the T2 high or T2 diffuse low signal change, or the huge motion and the severe back pain at 1 month, are related to the non-union. And there are many types of the vertebral augmentation. The vertebroplasty and balloon kyphoplasty are very famous, but recently the vertebral body stenting or some other device are used in the worldwide. What is the difference of the BP and BKP? And BKP can make the space by the balloon dilation. However, the BP and the BKP are equally effective at alleviating pain and enhancing function in the treatment of OVF. However, the cement leakage is more frequent in VP, and the cement leakage is more frequently, especially in cases within 2 weeks. And so far, there is no difference between BKP and VVRs in terms of cement leakage and local kyphosis. What about the timing of the balloon kyphoplasty? This is a systematic review. The paper investigated the result between the early group and the delayed group, and the early group is determined from the 1 day to 10 weeks. It's depending on the papers. And the result shows the adjacent vertebral fracture is less in early phase. But no apparent difference in the cement leakage between the two groups. And our previous study demonstrated that the vertebral height and kyphotic angle before and after balloon kyphoplasty were significantly better in patients who underwent early kyphoplasty. Additionally, the back score for low back pain at the final follow-up was better in the early intervention. So I will show a case of the VVS, 85 years old female. This case has L3 OVF, and in the supine position, we can see the intervertebral cleft, and on CT, we can find the posterior wall injury. These are pictures during surgery. At first, we insert needles. This is the most important point because if we perforated the medial aspect of their pedicles, which is a great risk for cement leakage into the spinal canal. This is the other case. This shows the cement leakage into spinal canal from the perforated space. So correct procedure can predict cement leakage. In this case, we use a stenting system. So we enter the stent in the body and dilate using the balloon system. And we check all the epi view and lateral view and insert the bone cement until the part of the posterior portion, but not to beyond the posterior aspect of the vertebral body. This is a picture after surgery. The patient's postoperative course was good. However, the BKP has a problem. The common problem is the adjacent vertebral fracture, and it's rare, but sometimes we encounter the revision surgery. The incidence of adjacent vertebral fracture is relatively high, with the rate ranging from 10 to 38% after balloon kyphoplasty or vertebroplasty. Most of adjacent vertebral fracture occur within 2 months, and usually the treatment of the fracture is conservative treatment. The adjacent vertebral fracture is associated with back pain, especially at 1 month after the onset, and also increase the risk of surgery. The risk of adjacent vertebral fracture are reported as there are many papers, but this report that the risk was the lumbar junction, old fracture, severe compression, and much collection. And they make their scoring system, and if the score 5 or more, the risk is very high. How to prevent the fracture? There is no apparent evidence, but the several papers demonstrated that the posterior fixation might reduce their fracture, and reduced correction or less cement insertion might reduce the risk of the adjacent vertebral fracture. And predictive vertebroplasty reported as the effective procedure, but there is no apparent evidence this systematic review that the no apparent effect of the predictive vertebroplasty, so is the predictive VP, is not recommended. Anabolic agents were used to prevent fracture. However, there is no apparent evidence. This paper shows that anabolic agents cannot reduce the adjacent fracture, but can reduce the distant fracture. So the anabolic agents are useful in severe osteoporotic cases to prevent new fracture. Revision rate after balloon kyphoplasty or vertebroplasty were reported as 3 to 4%, and the main reason of the revision surgery is the adjacent vertebral fracture. But the cement leakage is reported as 2%, and rarely infection also the cause of the revision surgery. This previous report revealed the risk for revision surgery after balloon kyphoplasty. The revision rate was 3.7%, and the risk were huge angular motion, split type of fracture, and large endplate deficits. Recently, the classification from AO spine was used worldwide. This system consisted of 5 classifications: OF4, which means both endplate fractures, and OF5 is injuries with anterior or posterior tension bundle failure. Recent papers demonstrated that in OF4 and OF5, posterior fixation has better outcome. However, there is no apparent evidence of superiority of the posterior fixation so far. Take-home message: selection for vertebral augmentation is very important. Pain and radiological findings at 1 month are useful to detect the patients with poor outcome. Vertebroplasty has higher risk of cement leakage than BKP. Early intervention has better outcome. AVF is frequent complication after vertebral augmentation. The risk of AVF is TL junction, severe compression, and higher collection. The risk for revision is OF4, large angular motion, and large endplate deficit. Thank you for your attention.
Thank you, Dr. Takahashi, for your informative talk. So, I don't see any questions right now in the chat.
May I?
Yeah, please, sir.
Wonderful talk, Dr. Hasi. My question is, the increase in height of the vertebral body or the change in the kyphotic angle that is prompted or assumed to be because of the benefit of kyphoplasty. Is it because of the virtue of kyphoplasty expanding the vertebral body, or is it because of the mobility of the fracture, which in itself leads to the expansion of the vertebral body height?
So thank you for your question. So actually the vertebral augmentation has not so much the correction effect. So if the patients have the very huge motion and very unstable fracture, just only the vertebroplasty or balloon kyphoplasty is the cause of the loss of the correction. So in that case, we add the posterior fixation.
So is there a objective criteria of the amount of kyphosis or the amount of mobility which helps us to decide when only kyphoplasty versus when kyphoplasty plus fixation?
Yes, thank you for your question. So in my practice, so if the correction more than 15 degrees, so I prefer to select the posterior fusion surgery.
Right.
So,
Right.
but yeah,
Yeah.
thank you.
And in these cases, is there any way we can add fusion also, or you do open or you do MIS fixation in these patients?
Thank you. So in my case, so I just the fixation. I do not fuse the by the open technique. So I just perform the MIS technique. So, but I think that there is no apparent effect of the fusion technique. So I prefer the MIS technique.
Interesting.
Thank you.
Thank you, Dr. Takahashi. One last question, if I may, if the moderator permits. Yeah.
Yes, sir, please go ahead.
Please.
There are always chances in patients who are severely osteoporotic patients. When you put in a lot of cement, the cement tends to get loose over a couple of years due to enhancing mobility of the patients. So have you had instances of cement loosening in a couple of years' time? And if yes, what is the approach in such patients when you see a cement loosening related symptoms in the patient?
So in that case, so if the patient's comparatively young, so I perform the fusion surgery, sometimes use the anterior approach. And but if the patient is very old and very risky for the surgery, I just prescribe the painkiller or something. But if I perform the surgery, so I usually perform the AP fusion.
Yeah.
Because yes, I have some experience with the failure of the extend the posterior fixation.
Yeah.
So it's risk of the posterior fusion.
Thank you. Thank you, Dr. Takahashi. In fact, I would like to share our experience in last decade. We have seen a lot of our patients where only vertebroplasty or kyphoplasty was done. The chances of cement loosening and subsequent symptomatic worsening of the patient in 2 years' time is as high as 25%. So the choice of selection of patients where only vertebroplasty will help versus where supplementary fixation should be done. I think we are still looking for those objective criteria, but angulation of kyphosis to begin with, and of course the end plate fractures or the age of the patient and the extent of osteoporosis are some factors which help us decide whether fusion should be added to this or not. And it's a treacherous and a very painful situation for us clinicians to manage a patient with very loosened cement blob lying anteriorly, and the patient is unfit to do any kind of major reconstruction. Yeah, I would be happy if anybody else has experience to share. Dr. Chee, Dr. Wong, any loosened cement and a patient is symptomatic, how do we really manage them?
Yeah, I think maybe anyone from the group. Dr. Shin Oe, you want to comment on cement loosening after balloon kyphoplasty or vertebroplasty?
Yeah. Thank you for your question. So we also sometimes experience cement loosening after the BKP in the especially osteoporotic patient. So in my opinion, I apply the PTH therapy preoperatively, BKP, and after starting PTH prescribing I think the patient with cement loosening decrease. So recently I prefer to prescribe PTH before surgery.
Yeah. Thank you, Dr. Shin Oe. Thank you, Dr. Takahashi.
Yeah, I can I ask? Oh yeah, Dr. Wong, Prof. Wong, can you? Yeah, please go ahead.
Thank you very much. I'm a bit conservative. I know that most osteoporotic vertebral collapse, they will heal even without any intervention. But one of the good prognostic factor from the lecture, I know that early intervention may help the patient. So how should we balance? We are not overcuring or overdoing the procedures. I think that is one thing. The second question is a response to Vishal. I also, because I'm conservative, I don't do a lot of vertebroplasty or kyphoplasty. I wait until the patient really has a chance of developing non-union, very mobile segment. So at that juncture, I may try vertebroplasty or kyphoplasty. And shortly after that, if the patient's symptom remains severe and radiologically it doesn't look like to be very stable, then I will go posteriorly to do the fixation. So the late loosening of the cement is not commonly seen in my practice because I supplement very shortly after the vertebroplasty if the patient does not respond. That is my response to your experience. Thank you very much.
Yeah, thank you, Prof. Wong. Thank you, Chee.
Yeah, maybe Shinji, you can comment on Prof. Wong's first question is how do you decide how early to intervene surgically?
So yeah, so I think that it's the most important point because if we perform the vertebroplasty for all of the patients with the painful vertebral fracture, it's over indication. So I performed the conservative treatment for about 3 weeks, and after the patient, after the conservative treatment, if the patients complain of the severe pain, I perform the another examination, including the dynamic X-ray and the MRI. And if the patients show the risk factor for the prognosis, I decide the surgical intervention for the patients. So I think the 10 to 20% of the patients with clinical vertebral fracture match the criteria.
Thank you.
Thank you. Thank you.
Thank you.
Yeah, one short question for Dr. Shinji. One of the fearful complication is cement embolism. Yeah, so do you have experience of cement embolism in BKP? And what are your tips to avoid it?
Yeah, so fortunately, I have no experience of the pulmonary embolism after the balloon kyphoplasty because in my practice, I always use the balloon kyphoplasty. So some articles mentioned that the vertebroplasty is a risk for the balloon cement leakage to the pulmonary embolism. So especially in the acute phase, within 2 weeks, and the vertebroplasty is the risk factor for the pulmonary embolism. So in that case, you should take care and pay attention to the cement leakage during the cement injection. Thank you.
Thank you very much. I think we will move on to the next speaker. I would like to invite Dr. Shin Oe, who will be presenting on surgical instrumentation in fractures of the osteoporotic spine.
Okay. Thank you, Chairman and Moderator Chiu. I'll share my presentation. Can you see my slide?
Yes, thank you. I can see.
Thank you. Let me introduce my presentation. As COI. This is my reflection case. She's a 74-year-old female who has spinal kyphoscoliosis. And she underwent two-stage surgery, first lateral lumbar interbody fusion at L2 to L5, and 1 week later, she received the posterior spinal fusion T5 to ilium. And the post-operative was good, but 4 weeks after the surgery, she complained of transient muscle weakness in both lower limb. And as you can see, the X-ray shows T5 vertebral fracture. And she was admitted in my hospital. And the CT shows T5 vertebral fracture, but the destructive change was not so severe. But next morning on the admission day, she posed a complete paraplegia, and the MRI shows T45 spinal canal stenosis and disc herniation. So we performed the emergency surgery for T45 decompression and fused to T2. But unfortunately, even after the surgery, there was no change of the paraplegia. And 1 month after the surgery, slight muscle weakness was appeared in both lower limb. And eventually, the 1 year after the surgery, she discharged her hospital because she could walk with a handcart independently. And 16 months after the surgery, she can walk without any assistance now. So we sometimes experience such a miserable spinal cord injury or myelopathy after adult spine deformity surgery. But do you know the incidence of those? So we retrospectively reviewed our case 297 patients. The mean age was 68-year-old, and the UIB fracture rate was 25.3%, and the revision rate was 6.4%. And the spinal cord injury or myelopathy rate was 2.7%. And interestingly, the reason for spinal disorder was UIB fracture in 7 of 8 patients. Based on these results, we hypothesized to prevent UIB fracture can decrease such a myelopathy. But as you know, the cause of UIB fracture are multifactorial. So in this time, we focused poor bone quality. And there are many reports parasite hormone PTH can strongly improve the bone quality. So we started a prospective randomized control trial which compared PTH to bisphosphonate. There were need to take the PTH or BP at least 1 month before the surgery. This is still an ongoing study. So in this time, we report progress report the patient with over followed up 6 months. So so far 34 patients recruited, but 8 patients was excluded as follows. And in this time, we evaluate 26 patients, PTH group 13 patients, and the bisphosphonate group 13 patients. There's no significant difference, sex, age, and some background. And the days of dosage was about 60 days in both groups. And the number of fused vertebral osteotomy in PTH group was significantly high. This table shows the bone density and bone metabolic markers. Bone density, no change, and was no difference at the baseline and 6 months after the surgery. And the TRAP5B in BP group significantly decreased from baseline to admission day. And the P1NP group was significantly higher on the admission day compared to the BP group. This figure shows the change of bone mineral density in the proximal femur. The BMD in both groups did not increase from baseline to 6 months after the surgery. And this figure shows the change of TRAP5B. The red window shows the normal reference. And the TRAP5B in PTH group did not increase, did not change on the admission day. However, TRAP5B in BP group significantly decreased its bone resorption inhibitory effect as the admission approach. And this figure shows the change of P1 and P. The P1 and P PTH group, PTH in the P1 and P in the PTH group significantly increased from baseline to admission day beyond the normal range. Maybe it's due to bone formation effect of PTH. And this figure shows the change rate of TRAP5B. As you can see, the TRAP5 in BP group significantly decreased 39.1% on the admission day. Then that in the both group increase due to surgical intervention. This figure shows the change rate of P1 and P. In the PTH group, the P1 and P increased by 64.8% on admission day, but no increase was observed in the BP group. And at 6 months, both group increased due to the surgical intervention. This figure shows a comparison of anabolic window. The anabolic window in the PTH expanded by the admission day, but there was no expansion in the BP group. This is the key slide, the comparison of UIB fracture and the PJF. The difference is not significant, but the incidence of UIB fracture is twice as high in the BP group. And please look at the PJF. The PJF rate is 23.1% in PTH group. On the other hand, 61.5% in the BP group. There is a significant difference. So let me introduce past similar report. There are two reports from Japan, and they compared with a historical control group. And this table shows PTH is effective for preventing UIB fracture, but there is still no high evidence level trial. The strong point in our study is a randomized control trial, but incidence of UI fracture in our study is very high. Why? I think there are 5 reasons, and this time I show the 5th reason, the definition of UIB fracture. So I believe everyone consider this patient has UIB fracture after the surgery. But how about in this case? So she has no back pain and no PJ angle change after the surgery. How about take a look at vertebral height? That's the change. So in this study, even minor morphological change is considered as a UIB fracture. So also this figure shows BMD in PTH group did not increase. Why? So as you know, the PTH act on the cancerous bone. Then the lumbar spine also has high proportion of cancerous bone. On the other hand, the femur bone has high proportion of cortical bone. That's why the PTH has a lesser effect on increasing BMD in the femur. Its summary, To prevent spinal cord injury and myopathy from PJF, it's important to prevent UIB fracture. If there's any episode of bilateral lower extremity weakness, even if transient, do not hesitate to admit the patient up to MRI evaluation, as spinal cord injury can lead to catastrophic outcomes. Present study is still small number research. The use of PTH preoperatively may be effective in preventive UIB fracture. Thank you for attention.
Yeah, thank you very much, Dr. Shin Oe. Let me see any
thank you.
questions. Yeah, if there's no questions, maybe I will start with one. Yeah, I think you introduced the use of PTH treatment in even just now when you commented to avoid loosening, and also to now PTH may reduce the incidence of proximal junction fracture. So there are some reports that the use of PTH can cause cancer. And that's why usage of this PTH, it's must be careful to use it so that the worry of inducing cancer in patient. So what is your comment on this? Yeah.
Thank you, Professor Chiu. Actually, I don't know the incidence of the cancer due to the PTH. However, the advantage of usage in PTH is very high in the adult spine deformity surgery, because as you know, the very high incidence of mechanical complication in the adult spine deformity surgery, and the main cause of that is osteoporosis. That's why I think it has better to use PTH in the AC patient. But I'm sorry, I don't know the incidence rate of the cancer for PTH.
Okay,
yes,
so
Professor Wong, you have a question? Yeah.
Yes. I could not recall any recent research about the incidence of cancer, but in the past, people cite a study, but in animal, it may increase the malignancy for cancer, but not in human being. And the usage of parathyroid hormone has to be more than about 2 years before the malignant potential appear. So I personally feel that it is relatively safe. And I also want to echo Dr. Shin Oe's opinion. When the patient presents with neurological symptoms due to adjacent nerve failure, the chance of neurological progression will be very high. I also have quite a number of painful experience for patients become paraplegic, but unfortunately, some of them, they did not recover. So I totally support we need to intervene early if there is junctional failure with neurological deterioration. Thank you very much.
Yeah, thank you, Professor Wong. I agree with you.
Yeah.
Sorry.
Dr. Vishal? Yeah, sure.
Yeah.
Dr. Vishal. Yeah.
Thank you, Dr. Shin, for a wonderful lecture. In fact, I think I completely agree with you that parathyroid hormone is one molecule which is like a magic molecule in the millennium. And I think one thing that has changed the overall course in spine surgery is this parathyroid hormone. My question is to you is, do you use a combination therapy of anti-resorptives and anabolics in your practice, or you use a solo molecule? And my second question is, what's your experience about the new molecule romosozumab, which is shown to have a higher efficacy in bone formation and has led to lesser concerns of daily injection, 2-year therapy, and also any malignancy incidents? So romosozumab is a new molecule, but any experience? and whether you use a combination therapy or solo therapy.
Oh, thank you. As you mentioned, romosozumab also very strongly affect osteoporosis. So maybe, and it's my opinion. I heard my colleague, the romosozumab is stronger than PTH for the effect. However, in this study, started prospectively, so that's why. And we decide to use PTH. There's no choice, romosozumab. So, but I think PTH is also effective, but which I don't know which medication is better to use osteoporotic patient.
Maybe you can ask Dr. Shinji to comment on this.
Yes, I have comment about that. So in my practice recently, I usually use romosozumab, and I summarize the result about 100 cases. The romosozumab have the better outcome in terms of the screw loosening. And however, one of the disadvantage of romosozumab is the bone formation marker is suppressed after 4 or 5 months after the starting point. So it may affect the bone fusion, but in the real world data, so I have no data about the negative data of the romosozumab, but in the animal data or human data, the bone formation marker is suppressed after the 5 or 6 months. So that maybe the teriparatide have the better bone formation effect.
Yeah, I think the reason to this is that the current generation of romosozumab that is available has a as a artificial protein as a carrier, which leads to development of antibodies like salmon calcitonin does in a month's time, which results into antibodies preventing the actual efficacy of romosozumab in bone formation. And that is why its efficacy lasts for max 5 to 6 months, resulting into a current recommendation of use 1 per month only for maximum 6 months. Whereas teriparatide now, on the other hand, has got recommendations and FDA approvals for use up to 48 months without any increase in incidence of malignancy chances. So a combination of this, maybe the future doors are open, and we hope that something magical happens to see our patients having less incidence of loosening of implants, and we as spine surgeons continue screwing them more often.
So there's a question, any experience with the use of fenestrated screws to faculty? Yeah, Dr. Shinji, you can go ahead.
So I usually use the fenestrated screw for the osteoporotic cases, especially in the short fusion. Short fusion means that does not include the pelvis as LIV. So in that case, so I think the fenestrated screw is effective. But in the cases with pelvic fusion, the LIV is pelvis. So the very hard UIV fixation could provoke the PJK. So in that case, I think the fenestrated screw may increase the PJK. So especially in the patients with the pelvic fusion, LIV is pelvis.
Okay, Dr. Shin, would you like to add a comment on this?
Yeah, actually, I have no experience fenestrated screw. So because another institution, the doctor reported fenestration screw has many problems in the long fusion surgery. That's why in our institution we don't use fenestrated screw. That's why I have no experience.
Okay.
How about Dr. Anand? Do you have any comment on this? Yeah, Dr. Anand.
So we seldom use fenestrated screws. Only we want to do cementing along with the screws, but our experience is only limited with that.
Okay.
Maybe I can ask one question to Dr. Shin Oe. Yeah. Yeah. You mentioned one of in your lecture some methods to prevent proximal junction fracture. Can you tell us your tips on what are the things that you do to prevent this fracture besides PTH hormone?
Sorry, it means the surgical technique?
Yeah, surgical technique or anything that you would do, you know.
Yeah.
Bracing or yeah, anything. Yeah.
Actually, we have many reports about PJK or PJF, and we have many reports. So I introduce one of them. We put longer screw at the UIB, and we call it the occupancy rate of pedicle screw. It express the ratio between the screw length and the vertebral body length. And the screw length over 80% significantly prevent PJF. And because the mechanical stress decrease if we use longer screw. And yeah.
Do you brace your patient post-operatively?
Sorry?
Do you brace your patient post-operatively?
Yeah.
After station?
Routinely, the patient need to brace for 6 months.
What brace do you use? Yeah.
Hard brace.
Sorry? Yeah.
Hard brace.
Hard brace, okay.
Yeah.
Dr. Shinji or Dr. Anand, do you have any comments on tips to prevent PJF?
Yeah, so most of these patients with this osteoporotic fractures, they all have an inherent kyphosis. And when we operate, you should make sure that you don't make an acute correction and you try to bend the rod and to try to correct the deformity. So if you do so, the incidence of PJK significantly increases. So you have to contour the rod to the deformity, and then you shouldn't try aggressive correction, and you try to posteriorly fuse it as well. And as far as the upper construct is concerned, you direct your screws on not towards the upper superior end plate, but you direct it little inferiorly. I think these things may help in decreasing the incidence of PJK.
Any last comments, Dr. Yatwa?
Well, this is a difficult question. I think we have to be individualized. Apart from those methods, our previous speaker already mentioned, I myself will try to minimize the number of fusion level or stabilization level. I think the longer the fusion, although it seems providing better fixation, but at the same time, it also increased the lever arm on both ends of the fusion. So the one I would like to add is try the best to minimize the level of fixation. I routinely use cement reinforcement. That means cannulated screw and then inject cement through the screw. I hope that it can give better fixation so that I don't need to extend too long the fixation. And also the cement at the end level may also help to stabilize that particular level. I think that is my routine practice. Thank you.
Okay, if I think we can go ahead. So Dr. Vijay Anand will be presenting on sacral insufficiency fracture.
So, respected seniors, distinguished members of the APSS, and my dear friends, good afternoon, everyone. So, my talk would be on the sacral insufficiency fractures. So, I have no conflict of interest or disclosures to declare. So, insufficiency fractures are a type of stress fracture that results from normal stress applied to an abnormal bone where there is a relative decrease in resistance offered by the bone. So the most common location for this insufficiency fractures are the pelvis, and that too especially the sacrum. The first description by sacral insufficiency fracture was given by Lurie in as early as 1982. So this entity is more common in the elderly women with severe osteoporosis. So why should we know about this entity and what is its significance? So this is one of the most commonly missed diagnoses in our clinical practice, and that leads to persistent pain and morbidity to the patient. And also this insufficiency fractures are a sign of frailty, and studies have reported that the 6-month mortality rate following a sacral insufficiency fractures is around 9.8, and 1-year mortality is at 18%, and 3-year mortality is 25.5%. Therefore, it becomes important for you to recognize this problem early and treat it aggressively. So the true incidence of sacral insufficiency fractures is unknown. However, it is presumed to be 4 to 5% in at-risk population, and the incidence increases with age. The frequency is more common in especially patients who are elder, more than 70 to 75 years, and they have a female preponderance of 2:1 ratio. So the common risk factors are the most osteoporosis and vitamin D deficiency, and there is a long-term steroid usage, and bisphenol also predisposes to this condition, and pelvic irradiation for malignancy, multiple myeloma, and other conditions. It causes bone weakening like on a renal osteodystrophy and hyperparathyroidism are also risk factors. Also, conditions such as spondylolisthesis and previous lumbar fusions and previous total hip replacement surgeries alter the loading pattern and biomechanics and can predispose to sacral insufficiency fractures. So the clinical presentation is usually a patient complains with a vague low back pain, and occasionally they may have the pain in the buttock area or in the groin area, and the pain typically aggravates on weight bearing. The radiculopathy symptoms are not routinely described, and it is very rare. Only in 2% of people there may be a S1 radiculopathy, and antecedent trauma is present only in one third of the patients, and even if it is there, it is usually a trivial trauma which does not warrant attention. The clinical examination, one may find a local tenderness around the sacrum, and the hip movements may be painful, and the sacral iliac joint stress test may be positive. So coming on to the diagnosis and the evaluation. So the diagnosis of this condition is often delayed. This literature reporting a mean delay of 40 to 55 days from the symptom onset before a dedicated sacral imaging is pursued. And studies also quote that the radiologists miss about 23.5% and clinician miss 76% of sacral insufficiency fractures on the routine imaging, and therefore a strong clinical suspicion is required in at-risk population. So on evaluation, plain radiograph is the least sensitive modality. So the bowel shadow and the osteopenia often obscures the fractures, and only in 20 to 38 of patients the fracture is visible, and even the fracture line is not evident in most, and what you could see is only the sclerotic margins. So CT scan may be indicated in patients with negative radiographs with high suspicion for fracture. However, the most usefulness of the CT scan is to assess the combination of the fracture, and especially if you are planning a treatment like sacroplasty, we need to evaluate the CT for their extension of the fracture into the neuroforamen or the central canal. So the MRI scan is the most sensitive and the gold standard for diagnosis of the sacroiliac insufficiency fractures, and it can detect the fractures by detecting the marrow edema as early as 18 days. And it can also differentiate between the malignancy, and is helpful in detecting additional pathologies like vertebral fractures or associated lumbar canal stenosis. So in MRI scans, though T1 and T2 weighted images can show the fracture, the best superior images is offered by the stereo images, which can show a hyperintense margin, and the fracture can hyperintense margin within the edematous sacrum. So the next investigation that is routinely performed is bone scan. So in inconclusive cases, the bone scan can be helpful in diagnosis of a sacral insufficiency fractures with a sensitivity of around 96% and a positive predictive value of 92. So the posterior planar images where the sacrum is close to the detector is the most sensitive location, and the Honda sign, which is the diagnostic of sacral insufficiency fracture, is however seen only in a small percentage of 20 to 40%. So coming out to the fracture patterns, the most common location of this insufficient fractures is in zone 1 in the sacral ala, between the ipsilateral neuroforamen and the sacroiliac joint. The bilateral fractures are the commonest ones, which is reported in around 55.8%, and around 88% may have an associated insufficiency fracture elsewhere in the pelvis. So compared to the traumatic sacral fractures, which can involve the neuroforamen, central canal, and are often unilateral, the insufficiency fractures are usually in the sacral ala and are usually unilateral. So the next most important thing is to evaluate the bone mineral density of the patient by a DEXA scan, because studies have reported the average T-score is between -2.5 to -3.7, and also other investigations like vitamin D, serum calcium, serum phosphorus, parathermone levels, and multiple myeloma also has to be evaluated. So coming on to the treatment, the goals of this treatment is to provide pain relief and to treat the underlying osteoporosis and help the patient to mobilize early, thereby preventing the complications of long-term immobilization. So the conservative treatment is by a brief period of bed rest. Usually patient is advised of bed rest for a period of 2 to 3 weeks, and analgesics in the form of paracetamol and low-dose opioids is recommended. However, it is better to avoid NSAIDs because they may impair the bony healing. So once the pain starts coming down, the patient is encouraged to walk with the assisted walker with the help of a walker, and breathing exercises and DVT prophylaxis also may be recommended in case of chronic rest. So as far as the osteoporosis treatment is concerned, my previous speakers have spoken. So the calcium for a minimum of approximately 500 milligram elemental calcium per day, and vitamin D of 800 international units, and calcitonin nasal spray, and bisphosphonates, and more importantly, the recent the parathermone analogs like injection teriparatide and can be given for the bony healing. So recently, the physical stimulation methods like pulse electromagnetic fields, the low intensity ultrasound, and extracorporeal shockwave therapy have been advocated in sacral insufficiency fractures because they can stimulate the osteoblastic activity and help the bony healing. So coming on to the surgical management, surgical management is indicated in patients who have persistent disabling pain despite conservative treatment. Sacroplasty and internal fixation are the two modalities of management. So percutaneous sacroplasty is akin to vertebroplasty in the sacrum. It was first described by Mark Garant in the year 2002. So the indication is cases where the conservative treatment has failed and the fracture is only minimally or undisplaced. So it helps in decreasing the pain and help the patient to mobilize early. So CT scan is important before you plan a sacroplasty. So you have to identify if there is any extension of the fracture into the neuroforamen, because that can lead to cement extravasation and neurological deficit. So this has to be evaluated by a CT scan thoroughly. Coming on to the technique of percutaneous sacroplasty, this is a case example where a 72-year male with a left-sided sacral ala insufficiency fracture, we did a sacroplasty, and the patient is position prone, and it is done under local anesthesia with a 0.5% bupivacaine infiltration and a mild IV sedation. So though this procedure can be done under CT guidance, we prefer to do it under CM guidance because we can monitor the cement extravasation and act promptly. So we routinely use a posterior approach and a short axis technique. So the technique involves prone position and getting a good images of the sacrum. So you have to make the L5 and S1 end plate parallel, and you should be able to visualize the sacroiliac joint and the gantry should be placed accordingly, and the Jamshedi needle is directed and targeted towards the sacral like it is shown in this picture. And in some cases you may need more than one needle for the cement placement all over the ala. So on the lateral X-ray, so the target for the needle is the junction of the lines connecting the corners of the S1 vertebrae, and the trajectories can be either parallel to the L5S1 disc brace, or it can be neutral with respect to the patient, or along the long axis of the sacrum. So this is the needle placement at the junction of the line connecting the corners of the S1. So once you are at the location, you inject a small quantity of around 0.5 to 1 ml to see how the cement spreads over that area. And once you are sure that we are at the right location and there is no extravasation, you continue to inject more cement. Totally around a quantity of 2 to 6 ml cement is injected under Shyam guidance with frequent shoot to make sure that there is no cement extravasation. So this is the post-operative X-ray of the patient. Once the procedure is over, the patient is kept in supine position for a period of 30 minutes, and the patient can be mobilized on the same day after 2 to 3 hours. So the complications of sacroplasty include cement leakage, and especially if there is a S1 radiculopathy, if the cement extravasates into the neuroforamen, or L5 radiculopathy if there is an anterior cement extravasation. And pulmonary embolism can also be is a known complication which can happen with cement injections. And if there is a fracture after the cement injection also, then implantation surgery may be required. So the other described technique for sacroplasty is a long axis approach, where there is a single needle inserted between the S3 foramen and the lower aspect of the SI joint. The advantage being that it only requires one needle, and it helps in providing a better cement distribution and decrease the risk of anterior cortex violation. However, we prefer to do a posterior approach, which we are used to. So coming on to the outcomes of the sacroplasty, there is a prospective study which have evaluated the outcomes in 52 patients with a mean age of 76. They have shown that the VAS score consistently decreases right from 30 minutes after the procedures, and the effects on the benefits continue to improve over a period of 1 year. And there is only one case of S1 radiculitis. So this is a meta-analysis of 19 studies which have evaluated the technical and clinical success, and they reported a 98.9% technical and 96% of clinical success with a very low complication rate of 0.3%. And they continue to show that the VAS scores continue to improve over a period of 1 year. So other modalities of surgical management include internal fixation. It is indicated in patients where there is a displaced zone 1 injury after failed non-operative treatment, or zone 2 or 3 injuries after failed conservative managements. However, the major disadvantage of this technique is that it requires general anesthesia. So the internal fixation options include unilateral iliosacral screw, the transsacral screw, or posterior bridge plate. The unilateral iliosacral screw is where the 1 or 2 7 to 8 millimeter cantilever screws are injected under Shyam guidance, perpendicular to the fracture plane, and you have to make sure that the screws cross the midline, and the stability of the screws depend on the bone quality. So compared to 1 screws, 2 screws offer better stability, and you have to use a washer to prevent the screw from getting buried into the posterior cortex of the ilium. So transsacral screw technique is a similar one, but it's directed all the way through the sacrum into the opposite side under Shyam guidance. So there is a meta-analysis of the comparison of surgical techniques, which showed that the superiority of sacroplasty, where compared to the other techniques, sacroplasty has offered a significant reduction in VAS scores. The next technique was screw fixation along with the augmentation, whereas conservative management and screw fixation technique have offered only very marginal improvement in the VAS scores. So to summarize, sacral fractures are most commonly missed entities, so therefore a strong clinical suspicion is required in elderly patients. MRI is the best investigation to detect these occult fractures, and to begin with, conservative management and osteoporosis should be managed, and if the patient continues to have significant pain, then sacroplasty is a safer and a promising procedure to allow the patient to mobilize early and prevent the complications of immobilization. Thank you.
Thank you, Dr. Vijay Anand, for your talk. Yeah. Any questions from the floor? And Dr. Chee, Dr. Vishal.
Yeah,
Yeah,
I
Dr.
can ask
Shinji wants. Yeah.
Yeah.
Dr.
Can I ask
Shinji,
a
please.
question?
Please
Yeah.
go ahead. Yeah.
So as you mentioned, I think the cement leakage into the S1 foramen is the very risk for the patients with the fracture line in the foramen. So if there is a fracture line in the S1 foramen, do you avoid the sacroplasty and do you perform the fixation?
So if there is a severely comminuted fractures, yes, we would definitely avoid a sacroplasty and would prefer an internal fixation. However, if there is only a minor fracture line with no displacement or no comminution, then we may do the sacroplasty under controlled. We may do under Siam control. We will first inject a little lesser quantity and see if there how the cement spreads, and depending upon that we decide if there is a cement extravasation. If the cement is spreading near the foramen, then we would not further inject any more amount of cement.
So usually, how much cement volume do you
So
inject?
approximately 2 to 6 ml per
Okay,
side.
thank you.
Yeah, I would like to ask, is there any role of conservative treatment, and who do you decide needs surgery and who doesn't need surgery? Yeah.
Yes, in every patient, first to begin with, we offer a conservative management that is recommended. So at least for a period of 2 to 3 weeks time, and then you call the patient for a follow-up in 2-3 weeks and see how they had responded to the analgesics and your calcitonin nasal spray or osteoporosis management. So though in this particular condition, patients they tolerate pain very less, and only 50% of the people have a significant improvement of pain. However, 50% of them still continue to have pain, and in that cases, they are offered the choice of sacroplasty. And if the patient is willing, then we go ahead and do the sacroplasty. Or if the patient is not willing and they want to continue conservative treatment for more period of time, then we have to go with that and see again how they're responding in a subsequent 3 weeks.
Yeah, one of the risks that we are worried about for conservative treatment is the impingement or injury to the cauda equina, especially the sacral nerve roots. So do you have any experience how often it can occur in conservative treatment, and what do you advise if you want to start conservative treatment?
Thank you, Dr. Chee. Okay, in insufficiency fractures where there is a fracture line is only in the ala, the chances of this cauda equina is very less. However, when there is a transverse fracture, then the risk of cauda equina is definitely there, especially there is a combination or a displacement. Then I think it's preferred to fix the fracture early rather than to wait for more and observing.
Yeah, Dr. Wong, your experience with sacroplasty or any other faculty's experience? Dr. Wong.
Well, I don't have too much experience on that. I normally treat the patient conservatively, and if fail, I normally will go ahead for fixation rather than sacroplasty.
Dr. Shin,
Professor
would
Wong,
you like to add something?
Sorry, just to add on,
Yeah,
what is your preferred method of fixation, if I were to ask? Yeah.
I normally will try percutaneous screw, use 2 screws under X-ray control to fix across the sacral ada.
Yeah, Vijay, you can go ahead. Sorry.
Yeah, Dr. Shin, would you like to add something to the discussion?
Thank you. Actually, I have very. I think this is very interesting, and recently we also experienced like this insufficiency sacral fracture, and some patients complained radiculopathy. the Dr. Suri also showed the L5 radiculopathy, but we also explains even the L4 radiculopathy. But fracture located S1 or S2 region. So we don't know why the patient complained like this radiculopathy. Do you know the mechanism of this?
So the ventral cement leakage can irritate the lumbosacral plexus and the lumbosacral trunk, and that could be the reason for the L4 radiculopathy as well. Anterior cement leaks.
Thank you. And if patient complain the radiculopathy, their pain is very, very severe. So we normally apply the surgical intervention without conservative therapy. How do you think about it?
So if the patient has radicular symptoms, then it can be managed by giving a selective nerve blocks.
But we explained sometimes it's very less effective for the patient.
Yeah, so
maybe it's only short time.
Yeah, so far we had seldom had any patients with the sacroplasty having a radicular symptoms, but I remember only one case a couple of years back having a kind of S1 radicular symptoms, and then that settled with selective nerve block. But I haven't seen any more radiculopathy that is very severe after this sacroplasty techniques.
Okay, thank you.
It would be interesting to know if at all I see a patient, what next. Yeah.
Thank you.
Yeah, Dr. Vijay, I would like to ask. Yeah, you mentioned that this condition is commonly missed. So, what is your advice to increase our detection rate for this kind of fracture,
So
especially when we see the patient in the clinics or in the hospital emergency department? Yeah.
Yes, Professor Chee. So when you have an elderly patient with the severe excruciating pain in the low back where you are not able to localize clinically, so you have to make sure that you have to inform your radiologist to screen the sacrum and the sacroiliac joints as well. And especially you have to include the coronal stereo images of the sacrum to detect these fractures. That should be part of your routine screening in our hospital. As a protocol, we when we do the spine imaging, they include the sequences of the sacrum as well.
Yeah, that's very good. Yeah.
Any comments from other faculties or any the panel? Yeah.
If not, we'll go ahead with the case discussion.
Yeah, so maybe I will introduce Dr. Sato as the next presenter. Dr. Sato will be presenting on a case in this topic. Yeah, Dr. Sato, you can go ahead and share your screen.
Good afternoon to the moderators and also respected spine surgeons from the APSS fraternity. I am Saturvelthan from University of Loya, Kuala Lumpur, Malaysia. I would like to present a case of osteoporotic fracture today. The slides are not going. 1 second. Okay. So, the 72-year-old lady presented with low back pain for the past 4 months. She had a history of fall in the bathroom, which was preceding the onset of pain. The pain was instability in nature, especially on changing positions and getting up from the bed. There were no lower limb radicular pain, weakness, or numbness. The urinary and bowel was normal. There were no other red flag symptoms as well. On examination, there was tenderness over the lower thoracic spine and bilateral paravertebral region. The upper limb neurology were normal. Sensation over the trunk and lower limb was intact. Lower limb myotome was generally normal, except for the hip flexion, which was 4+ due to the back pain. Otherwise, there was hyperreflexia noted over the knee and ankle. Babinski was downgoing and there was no clonus. Whole spine radiographs shows the T11 vertebral fracture with the kyphotic deformity or the thoracolumbar region. There were no pedicle or end plate erosions noted. Dynamic stress tolerance was subsequently done, which revealed an intravertebral cleft at T11 region, which were more than 4 mm in size. Subsequently, we did a CT scan, which shows vacuum sign at T11 vertebral region, as well as retropulsion of the fracture fragments into the canal, resulting in narrowing of the spinal canal. The MRI T2 weighted image shows the intravertebral fluid sign, indicating of cleft and compression of the spinal cord at the mid-sagittal region, as well as in the axial cut, whereby we can see at the pedicular level, story 3, there were compression over the spinal cord. So a diagnosis of T11 osteoporotic fracture with intravertebral cleft and spinal cord compression was done. So I will leave the discussion to the expert panel for the management part. Thank you.
Yeah, Dr. Sato, can you reverse to the one of the either the MRI or the CT? Maybe we'll start with the invited faculty. Maybe Dr. Shinji, you would like to start. What is your comment on this? What would you do?
Yeah, so this patient have the back pain and the subclinical cold injury. So in that case, so this patient also have the non-union, and I think the end plate fracture is very severe. So the just vertebroplasty is very difficult to keep the correction. So in that case, and the fracture is very unstable. So in that case, I will perform the fusion surgery, and the patient is not so old, 72 years old. So if the patients have no severe comorbidity, I want to perform the AP fusion.
Can you explain AP fusion? What would you do?
AP fusion using the expandable cage. So if we use the expandable cage, we can perform the MIS technique. So not so major, not so complicated surgery. So one opinion, but yeah.
Yeah, okay, thank you. So that means how about posterior fixation? How many level would you fix? Or
so in that case, 2A, 2B fixation.
Okay. So 8 screws.
And I think in this case, I think use the fenestrated screw.
All right. Maybe Dr. Shin Oe, would you want to comment on this?
Yes. Could you show me CT?
Dr. Sato, can you show the CT?
Sorry, 1 second.
So maybe this patient has a neurological symptom, but the muscle weakness. Maybe this fracture causes her muscle weakness. So my first opinion is AP fusion as well as Dr. Takahashi. But if she has less neurological symptom and no severe stenosis, I maybe perform the posterior spinal fusion with BKP. But maybe she has neurological symptoms, so I will perform AP fusion 2 above 2 below. Yeah.
Okay. Dr. Anand, Vijay Anand, any comment on this? Dr. Vijay Anand, do you have any comment on this? Yeah.
Sorry, my mic was off. I prefer to do a fixation from the posterior 2 or 3 segments above and below, and then I would decompress and would do an anterior reconstruction through an all posterior approach via Harm's cage.
Okay. Professor Wong, do you have any comments? Or Dr. Vishal, do you have any comments on this? Yeah.
Yes. I think I will also go ahead for surgical fixation. I will do all posterior. There are 2 methods of posterior fixation. One is posterior reduction osteotomy. Do a wire laminectomy, remove the posterior bulging bony fragment, and then compress the posterior element. So with reduction osteotomy, because the anterior end plate of the fracture vertebra will collapse completely, so the anterior stability is restored. I think that is one thing. Especially if this is a fresh case, because normally for fresh case, the bony fragment is not very adherent to the dura, and it's very difficult to, it's not difficult to remove the ventral pulse bony fragment. So reduction osteotomy is one. The second method is exactly what Dr. Anand said, dual posterior, and since this is T12 fracture, am I correct?
T11 fracture.
11 is even better, because 11 we can sacrifice the nerve root on one side, and then do very easy discectomy, as well as remove the T11 vertebral body and put in anything, any cage or even mesh to support the anterior corner. And this is more applicable in more chronic case, especially if the ventral pulse bony fragment is very adherent to the dura. Thank you.
Yeah, thank you, Professor Wong. I think to summarize, one is, I think all the faculty and Professor Wong agree that surgery is needed for this patient, and there is involvement of both anterior column and posterior column fixation. So with different methods suggested by different faculties. All right. So any more comments or any question on this? Okay. So if there's no comments, maybe we can move to what you have done, Dr. Satu. Yeah.
So what I've done is, first I did a MIST fixation T9L1 with the fluoroscopic guidance. We use a Bandini rod bending system, which helps to address the sagittal as well as coronal angulation and reduces the stress on the fixation. And this is a slide shows post MIST and both rods was inserted. And subsequently, I did a vertebroplasty over the T11. And the image shows there's a cleft pattern, cement distribution. And this was the post-op radiographs, whereby the T11 percutaneous vertebroplasty was able to have some anterior column support, as well as the MIST fixation was useful for reconstructing the sagittal alignment as well as indirect cord decompression. So the sagittal alignment was improved for 50 degrees kyphosis to 20 degrees post-operatively. And the rationale of our treatment was anterior column support was obtained by percutaneous cement intervertebroplasty of T11, MIST T9L1 for indirect decompression of the cord and sagittal alignment correction. Fixation was achieved with minimal invasive technique with less morbidity. Post-operatively, by day 2, pain was minimal and patient was started ambulating on walking frame. Thank you.
Yeah, can you go back to your X-rays? Thank you. Yeah, so any comments from anyone about this method? What would you have done, or what can you suggest that that can be done better? Yeah. Anyone? Yeah, Dr. Shin Oe, yeah. Okay, Dr. Shin Oe first, yeah.
Yeah. I have one. I think it's a good option, but I also commented if this patient has no neurological symptom, I'll perform the posterior spinal fusion with BKP. But in this patient has neurological deficit, but you perform BKP and the posterior spinal. Yes.
Generally, patient had hip flexion power of 4, and then slightly increased hyperreflexia of the knee and ankle. Otherwise, no other deficits were noted.
Oh, she has no neurological deficit?
Yeah.
Oh, sorry, I misunderstand. Okay. But so she has no muscle weakness, right?
No muscle weakness, yes.
Okay. Thank you.
Thank you.
Yeah, I think what Dr. Sato presented is there's some hyperreflexia. Maybe there's some cord irritation. It's over 4 months, right? This fracture.
Yeah, over 4 months. Yeah.
Yeah, so there is some nerve compression symptoms, but it is not severe. Patient is still able to ambulate and walk. Yeah. So that's why it is a bit on the borderline side, whether you want to treat like a patient with neurological deficit or not. Yeah. Any comments on this? Yeah.
I think this is really is borderline, and I think this is a good option. Minimal invasive, less surgical trauma to the patient. So it is a good option for the patient. I just want to bring up one point. During the surgery, we should try not to compress across the fracture. Otherwise, it may shorten the middle column and making the retro portion of the bony fragment more severe and cause neurological deterioration. I think that is the point I want to alert the audience. The second point is, I wonder whether the integrity of the MPA is an issue for you to choose this technique. Because if the MPA is very convoluted with a lot of fracture, will the vertebral plastic be well supported by the bony MPA? What's your opinion?
Yeah, I agree with that point, but based on the CT scan, it shows that both endplates were affected. However, when I was injecting the cement, there was a cleft pattern, and then that's why I proceeded with the cement injection with vertebral plastic. Thank you.
Yeah, just to give some feedback to Professor Wong, in our center, we are a bit more conservative. We try to do minimal invasive if possible. And a lot of times, this patient with cleft fractures has also broken integrity of the end plate, like what you say, and we have injected cement into it. And a lot of times they do able to have fracture union, or they instead of fracture union, there is a bone bridge that actually fuse to the next level to some extent. Yeah. Professor Shinji, just now you said you want to ask a question. Yeah.
Yeah. So I wonder the long clinical outcome. So how long did you follow up these patients?
I just did this case like last month, so I need a longer follow-up to present on the prognosis of this patient. Maybe on next time I'll present on the progress of this patient.
Yes, because
But this is a routinely done procedure in our center. So we have done few cases.
because if the patients have the very severe kyphosis and receive the correction surgery, the screw loosening is very common complication after such this case. So yeah, so and this patient is about 73 years old. So you have to consider the long-term results.
Yeah, so thank you for the comment. What would you have done differently to prevent this screw loosening? What is the thing you would have done? Yeah.
So one of the options is the fenestrated screw, and one is the I think the most important thing is the achievement of the bony fusion at T11. So if the screw loosening occur, the bony union is achieved, I think it's okay.
Yeah, I think just now Professor Wong did mention that you want to use a very short fixation to prevent long lever arm issues of failure. Any comment on this, Professor Wong? Yeah.
Well, I think 2 level above, 2 level below, I consider this as short fixation already. I probably won't extend to 3 level above or 3 level below. We sometimes, or I have occasionally some cases I did only 1 level above, 1 level below, but those are the bone quality relatively good. Those are, I consider it as exceptional case rather than routine.
Thank you very much. I think if no comments, I think thank you very much, Dr. Sato, for presenting this case.
Thank you.
Maybe I pass over to Dr. Vijay because I'm the next presenter.
Yes, so I think our moderator, Dr. Chee is going to present on the next case. So, Dr. Chee, please go ahead.
Okay, the next case is this 72 years old man. He fell from ladder about 1 meter high, complained of back pain, was seen in the emergency department, and he gave a history that he need assistance to get up and mobilize due to the severe back pain. Clinical examination, the severe back pain at the thoracolumbar lumbosacral area, especially when we want to turn the patient. And he has very much difficulty to sit up due to pain. However, the tone, power, sensory reflexes of the upper and lower limb are normal. He is quite a healthy man. He only has hypertension and is on treatment. So the radiographs of the patient was taken, and this is the radiographs. And if you zoom in at this region, in the thoracolumbar region, you found that there is a fracture that is involving the vertebral body, osteophytes, and also the posterior column. We also noticed that the spine are all ankylosed, probably due to dish in the pattern of the ankylosing spine. We did perform a CT scan, and we noticed that there's a fracture here, and the ankylosed spine above and below, and also posteriorly. You can see that there is a large fracture cleft of the fracture, and also this fracture goes to the posterior column. So 3D recon of the CT scan shows an ankylosed spine with the fracture going through all 3 columns of the spine. MRI confirms the diagnosis of acute fracture, and bone density is low. Patient is osteoporotic. So discussion. Maybe I pass over to the faculty and the panel. What we have done, any role of non-surgical treatment. If you plan for surgery, anterior, posterior, combined, fusion, non-fusion, short, long fixation. Any comments?
Perhaps I start the ball.
Yes.
Perhaps I start the ball rolling first. I personally will recommend surgery unless the patient refuses. Because of the long lever arm, the fracture is over T12, above and below are very stiff. So all the stress will concentrate at the fracture site. So even there is not much displacement, there is a high chance the patient will develop non-union or even neurological deterioration. So I would recommend the patient to have surgery.
So I would also agree with Professor Wong. So there is a high risk of late onset neurodeficit in this fractures on conservative management. So I would prefer to do the surgery firsthand. And because of this fused spine, it will require long arm fixations, 3 segments above and below. And we should be very cautious on positioning the patient as well to make sure that the fracture doesn't displace on prone position. You have to maintain the kyphotic attitude and then go ahead and do the fixation. So if it is a fresh fracture, then you are able to see a good reduction of the fracture in the C-arm. You don't need an anterior reconstruction. However, if there is an opening of the fracture on positioning, then it may need an anterior reconstruction as well. But in fresh fractures, you may get away without that, only by stabilization alone.
So would you, how many screws would you use, Dr. Vijay?
3 above, 3 below, because of the long lever arm being a fused spine.
And will you do fusion or just fixation?
In fresh fractures, no. If the fracture is aligned, it's in there is no opening up of the fractures on prone position, that I would just do a stabilization in fresh fractures. However, is it if the patient presents late and there is a significant gap ventrally, then I may do an anterior reconstruction as well.
Dr. Shinji, Dr. Shin Oe, any comment?
So in my opinion, the other some other doctors said, so I also performed the long fusion, only posterior fixation, 3 above and 3 below. And also I think I will use the teriparatide, which can promote the bone formation in the ankylosing cases.
Yeah. Dr. Shin Oe?
Yes. I also performed the surgery because this is a reverse chance fracture. It's very unstable. And I will fuse 3 above, 3 below, and without bony grafting, because this patient has easily achieved the bone fusion. So after 1 year, I removed the implant after achieving the bone infusion. Thank you.
All right. Any other comments from anyone? Okay. So if there's no comments, I'll show what we did. We performed the minimal invasive stabilization without fusion. And we augmented the anterior column with cement vertebroplasty. Yeah. So any comments now from anyone on this, what we have done?
So this cement is leaking to the upper vertebral cord.
Yes. Yeah, here you can show that we inject, because it's a fresh fracture, so there's a fracture to the end plate, is it leak anteriorly and to upper side. I think more of upper lateral side. Yeah. There's some leakage. Yeah, I agree. But there's no intraoperative complication for this patient. So
So I think in that case, so there is no anterior support like or something. So the cement leakage easily occur.
Yes, I agree. On this comment, because it's a ankylosed spine, maybe all this ligament has already ossified or already not functional, or yeah, so that's why there is a higher chance of leakage. Yeah. Anyone would like to comment that we can on what we can do better or do differently?
Can I ask the question?
Yeah, sure. Anything.
Yeah.
Any questions? Yeah.
So maybe in my institution that we don't perform the cement because the patient with this has easily achieved the bone union. Maybe if we don't perform the cement, maybe the patient can achieve the bone fusion at the fracture site. How do you think about it?
Yeah, I agree. Yes. So we are worried because of the stability. Maybe that's why we augmented anteriorly. Because patient is osteoporotic, we are not sure whether this posterior implant itself will have a risk of failure. So therefore, we augment anteriorly to give anterior column support to prevent the posterior fixation from failure. Yes, I agree that if you do not put cement, the fracture, if it's not, the fixation is stable, the fracture will unite, like any fracture, and especially in patient with dish, he will unite. Yeah. Thank you for the comment.
Wong.
I think that's an option, not to put cement augmentation. Yeah, Vijay.
Yes,
Nothing
I would,
that's bring a discussion. Yeah.
Yeah, I would agree with Dr. Shin that in fresh fractures, yes, there is not a necessity to absolutely put a cement and you expect the nature to heal over a period of time, provided there is no significant gap at the fracture site. Only in late stages, when the patient presents late with a significant gap, then I would think about doing vertebroplasty as well.
So, any more comments? So I would summarize that most faculty would agree that to do fixation, whether only posterior, and in our case, we augmented anterior, but majority will just fix posteriorly. Yeah. So I'll show you what we did. After 1 year, we perform a CT scan. And if despite the cement in front, the patient achieved union across the fracture. It's not so clear here, but if it's in 3D, you can see that the fracture has healed. You can see the back. The fracture is healed. And this is some time ago. After 5 years, the patient's implant and the cement is still in place without any loosening or failure. Yeah. So thank you.
Yes, so after this case discussion, I think we have come to the end of today's webinar. I'll be presenting the summary statement and I request Dr. Chee to give the vote of thanks. So we thank Dr. Wong, Professor Wong, for his inaugural address, and then Dr. Shinji has presented on principles of balloon kyphoplasty, and he has given a special note about what could be the problems associated with that. And Dr. Shin Oe has spoken about proximal kyphoscoliosis and proximal junction failure, especially in this age group of patients. And Dr. Vijay Anand has beautifully explained about sacral insufficiency fracture with a note on how to do sacroplasty. Dr. Saturvelthan has told us about osteoporotic fracture with a cleft and his minimal invasive treatment with vertebroplasty. And Dr. Chee has presented a case of ankylosing spondylitis with transosseous fracture and MIS treatment with anterior column reconstruction with cement. So that was for today. And Dr. Chee will tell about he'll give the vote of thanks.
Yeah, I would like to thank again especially the faculty, Dr. Shinji, Dr. Shin Oe, Dr. Vijay Anand, and Dr. Sato for taking your time to join this webinar and share your experience and your expertise. Also, I would like to thank the Secretariat for their work in organizing this webinar. All the preparation before this takes a lot of work and a lot of planning. I thank my co-moderator, Dr. Vijay, Loya, for also co-organizing this webinar. And thank you, Professor Wong and Dr. Vishal for supporting this webinar. And to all the audience and people who have attended this webinar, thank you for your time, and we hope that you will benefit from this discussion. Thank you.
Thank you.
Thank you.
So we will officially end this webinar. Thank you. Thank you for joining us. See you.
Thank you.
Bye.
Bye.
Thank you.
Bye.
Thank you.
Thank you.